All right, everyone, welcome to tonight's Canadian Continence Foundation lecture series. It's my pleasure to be joining you this evening. As the last few attendees join, we'll start with our introductions. So I'm Dr. Dean Elterman. I'm a urologist and associate professor of urology at the University of Toronto. And it's my pleasure to present tonight third-line therapies for refractory overactive bladder and urgency incontinence. The purpose of tonight is to really spend some time focusing on these difficult to treat condition of urgency incontinence and overactive bladder, and spend some time discussing some of the third line treatments, the treatments that are really reserved for difficult to treat cases and aren't often well aware of in the general population or in the referral networks of urologists and urogynecologists. So as I mentioned, I'm Dean Elterman. I'm a urologist downtown at the University of Toronto. I've trained here in Canada as well as the United States, and I have a special interest in functional urology, which includes overactive bladder and urgency incontinence. And I do perform all the treatments that we're going to be talking tonight. This is the University Health Network, made up of the Toronto General and Toronto Western hospitals, as well as Princess Margaret. These are my disclosures. I'm a consultant for a number of the companies, and of course, tonight's program is sponsored through the Canadian Continence Foundation. So in terms of objectives, I would like to briefly review the epidemiology and treatments for overactive bladder. We'll review Botox or Onabotulinum toxin as a therapy for OAB, including some of the outcomes. And we'll also review sacral neuromodulation as a therapy for OAB, including its outcomes. So let's begin with refractory overactive bladder. What are we exactly talking about when we say refractory OAB? Well, remember that overactive bladder is defined as urinary urgency, which is the sudden compelling desire to urinate, which is difficult to delay or defer. In other words, you have to go and you have to go right away. Urgency can occur with or without urgency incontinence. So that's incontinence associated with urgency, and it's usually associated as well with frequency and nocturia. Now we can define frequency as, how much is too much? How many times is too frequent to go to the bathroom? Well, if you're doing a diary, it would be 8 or more urination or voids in a 24-hour period. As I said, urgency is the main symptom that you need to have for the clinical diagnosis of overactive bladder. Urgency incontinence is that involuntary loss of urine associated with urgency right before you get to the bathroom, and nocturia is defined as waking up 2 or more times at night with the urge to urinate. So you can think of nocturia more as nighttime urgency. Your bladder doesn't go to bed, your OAB doesn't go to bed. And of course, you could have a bladder contraction or detrusor contraction in your sleep, which will give you the sense of needing to go to the bathroom all of a sudden. And in fact, some people won't even waken from sleep, and they can have accidents. They can have urgency incontinence episodes even in their sleep. So who is affected by OAB and how common is it? Well, nearly 1 in 4 adults over the age of 60 will experience OAB symptoms. So remember, urgency, frequency, or nocturia. More than half of men and almost 56% of women between 40 and 60 will experience some stored symptoms. So stored symptoms are, again, those OAB symptoms of frequency, urgency, and nocturia. Urgency urinary incontinence, or UUI, and OAB are the most common causes of incontinence in the elderly. And lastly, OAB has certainly been seen as a marker of frailty in the elderly, and it may actually be linked to cognitive impairment. So incontinence can be difficult to differentiate because you can have multiple causes for urinary leakage, and sometimes people aren't necessarily sure what is the cause of their leakage or incontinence. So overactive bladder OAB, you can have urgency with urgency incontinence, whereas stress incontinence is the involuntary loss of urine associated with effort. So coughing, laughing, sneezing, essentially putting stress on the bladder. Whereas urgency incontinence is that loss of urine associated either immediately before or with that sudden sense of needing to urinate, so the urgency. Now remember, many people actually have urgency frequency without having leakage of urine. And sometimes more confusingly is that people can present with both mixed urinary incontinence. So mixed means they have some urge incontinence as well as some stress incontinence. And of course, we'd want to treat each of these entities separately and individually because they have different treatments. The urgency incontinence can be treated with pelvic floor physiotherapy, oral medications, or these third-line treatments. And of course, stress incontinence can be treated with physiotherapy or types of surgery or bulking agents. As I just mentioned, in overactive bladder, only about a third of people with OAB actually leak urine. And the vast majority, 2/3, will actually have just urgency frequency without the leakage. So how widespread of a problem is OAB? Well, if you look at these United States statistics, overactive bladder is exceptionally common. In fact, it's more common than asthma and diabetes and osteoporosis and Alzheimer's. And so all of these other conditions get a lot of attention in the mainstream. And of course, not a lot of people talk about incontinence. And that's why, of course, the Canadian Continence Foundation is so important to help support patients from a grassroots level. FI, you'll notice here as a condition, is fecal incontinence. And that's not the purpose of tonight's conversation, but just remember that there are other forms of incontinence, and bowel incontinence or abnormal bowel leakage may also be something that many people deal with. And in fact, they can coexist with bladder and bowel conditions. So OAB is really a silent condition. Many people with OAB do not seek medical attention, and they opt to suffer in silence, possibly without realizing that treatments are available. And so the whole purpose of the Canadian Urological Association creating guidelines around OAB and having conversations like this tonight is to spread the word that OAB doesn't have to be a silent condition. And of course, there are many treatments available. OAB certainly impacts many aspects of quality of life, and it impacts them negatively. So from a psychological perspective, we see depression and lack of motivation. In the work, we see things resulting in loss of productivity, and there's an economic burden. We see isolation associated with anxiety and fatigue. Recreation, people don't want to participate in sports and hobbies. It can impede with sexuality and, of course, hinder daily life. When we want to evaluate incontinence and OAB, remember, we need to do a proper medical history and assessment. We need to be able to recognize urinary symptoms. Many patients will have physical findings such as rashes and wetness. And of course, we want to identify comorbid conditions. Urgency incontinence and bladder conditions can also be associated with other medical conditions like diabetes or dementia, bladder or prostate conditions as well. We also want to look at medications to see if there's anything that could be contributing or that we can modify. We also often ask patients to keep a diary to actually assess how much fluid they're taking in and how often they're having leaks. So we often ask patients what really bothers them. And we can ask whether it's they get an uncomfortable urge to urinate or the sudden urge to urinate, if they have little accidents along the day, and if they have any nighttime urination. These are the European guidelines for the management of overactive bladder in women. And I think these are a couple important takeaways as we get into the third-line therapies. So it's recommended to offer these classes of drugs called anticholinergic drugs to adults who have OAB who fail conservative treatments, such as dietary modifications or pelvic floor physio. You can offer what's the beta-3 agonist called mirabegron as an alternative to anticholinergic drugs if they fail conservative treatments. If these medications prove to be ineffective, you can actually increase the dose or actually have a different type of formulation or give these medications in combination. And there should be a little bit of caution exercise or a lot of caution exercise with the long-term use of anticholinergic drugs, particularly in elderly women, because they can be associated with the risk of developing cognitive dysfunction. So this is essentially a pathway looking at the different types of treatments. Up on the top left, you'll see behavioral modification. This is what we consider first line or conservative treatments. These can include things like modifying fluids or reducing fluids, avoiding bladder irritants such as alcohol or caffeine. Timed voiding allows the bladder to not get overfilled, which could trigger a bladder contraction. And Kegel exercises and other sorts of pelvic floor physiotherapy can be very helpful. Second line treatments are medications. First and second line treatments can occur at the same time, or they could be sequential. Here's a list of a number of available medications here in Canada. These are all considered antimuscarinic / or anticholinergic drugs, the exception being mirabegron, which is a beta-3 agonist. It works a little bit differently. Now, of course, if 1 or 2 of these medications don't work, then we move on to the third-line therapies, which is really the focus of tonight's conversation, which is going to be either Botox or neuromodulation. So let's get into sacral neuromodulation, and then we'll get into Botox after. I will also remind everybody that if you have any questions, there's a Q&A box that we'll be able to address at the end of my talk. So sacral neuromodulation. So what exactly are we talking about? So when we think about the urinary tract, what it requires is a neural coordination from the brain and the spinal cord. So essentially everything is connected via these neural or nerve pathways. Afferent pathways, they take sensory information from the bladder. And so you could think of this as the bladder slowly getting filled, and we're getting information about how full the bladder is. And you can think of a lot of this like the volume knob on a stereo. And so as the bladder gets fuller, this volume knob is going to increase, and that's the afferent sensory information. The bladder is sensing how full it is, and it's sending that information to the brain. In turn, the brain will interpret this as being not full, getting full, really full, and eventually it's time to go to urinate. And so it'll send what's called an efferent message, or a reciprocal message, down to the bladder, and that's the motor response. So that's the opposite of sensing. It's the actual squeezing of the motor. And the problem that we experience with overactive bladder is that there's a dysfunction. There is an imbalance between this afferent sensory neural pathways being sent up to the brain, and then the resultant information being sent back down to the bladder. And so what happens in overactive bladder, we've seen this in MRI studies and a number of other investigations, is that when the bladder is supposed to be nice and relaxed and calm, imagine that volume knob is turned down in someone who doesn't have overactive bladder. What happens is as the bladder fills in an overactive bladder individual, that volume knob all of a sudden turns up. It's like your toddler grabbing that knob and turning it up, down, up, down. And then the brain starts thinking, well, okay, well, the bladder is full, and it sends a message down for the bladder to squeeze. But of course, we don't want that bladder to squeeze because the bladder really wasn't full and we're not ready to go to the bathroom. And so that sudden squeezing of the bladder, the detrusor muscle, is what gives us the sensation of urgency. And so what happens is these bad messages get sent from the bladder, these afferent sensory signals. The bladder resultantly squeezes at inopportune times. We experience that as urgency. And in fact, you can lose a bit of urine, and that would be urgency incontinence. And so we have this imbalance of these inopportune, inappropriate messages being sent. And so then the key to neuromodulation is, can we actually change the signal? Can we actually change those inappropriate messages being sent? So that's where sacral neuromodulation, or SNM therapy, comes in. So this is a system which has been approved for a number of indications. It includes urgency urinary incontinence, urgency frequency, which remember is the overactive bladder without the leakage, 2/3 of individuals. It actually treats other conditions of the lower urinary tract, including non-obstructive urinary retention. So essentially the opposite of an overactive bladder is essentially no activity, retention. And of course, as I mentioned, fecal incontinence. So it treats both bladder and bowel incontinence. And because this is a third-line therapy, or for refractory cases, it's really for patients who have already tried some form of conservative treatment. It could be physiotherapy, it could be medication. But these therapies have been around now for well over 20 years or so, and there's been 300,000 plus individuals implanted. You can see on the right-hand side the system. So you can think a lot of it like this, like a heart pacemaker, right? So we put heart pacemakers in routinely. It's a little battery that goes in the chest and a little electrode that goes down to the heart to pace the abnormal electrical signals in the heart. So this is exactly the way I would explain this to patients. You have these abnormal signals down around your tailbone where the nerves for your bladder are. And what we're doing, just like the heart pacemaker, is we're changing those signals. So these small implants can be placed very easily, and we're going to go through that. There's been an evolution of what's called interstim therapy or sacral neuromodulation. We've had larger batteries about 10 to 8 years ago. We've moved to a smaller size battery that is a bit more comfortable and easy to have. And in fact, over the last year, we've moved over to having the option of not only having what's called the interstim 2, which is a primary cell battery, so one that has about a 5-year battery life that does not require any recharging. We've also added this tiny little battery you can see here in the blue. It's about the size of a USB memory stick, and that is a small rechargeable system. So patients have a bit of a choice. We do make some recommendations upon some of their characteristics, but these batteries go in, and they do get what this Samsung cell phone, and that acts as a remote control that can send messages to and from the battery, so we can turn it on, turn it off, change the channel, change the volume. And of course, if you have a rechargeable system, it comes with all of these accessories for charging the device, etc. So we've been able to see, based upon, again, some MRI studies, that those abnormal signals actually become normalized when we put in the lead, you can see here, and the electrodes, and give a very gentle current that essentially changes the signal that's being sent. And so you're no longer having those bad signals being sent up and down. The person has full control over their bladder, so they're able to get normal sensation of fullness. And when they want to go to the bathroom, they're able to voluntarily go to the bathroom. They don't have to push any buttons, nothing on the remote control. What the neuromodulation program is really doing is blocking out the abnormal signals, but allows the proper signals to get through. So as I said, these mild electrical pulses are on the nerves that control the pelvic floor muscle, the lower urinary tract, the sphincter. It can also control bowels through direct modulation. And what's really nice is that the bladder and bowel share a common nerve. And so we're able to treat both conditions essentially the same way. So before we give people a full implant, we're actually able to do what's called a nerve evaluation. And so before people come to the operating room to have one of these small devices implanted, we give them a trial battery. And the way we do this is that it's performed in an office. It's very simple. It's done under local anesthesia. Patients come in, they just lie down on an examination bed, and we're put in a bit of local anesthetic, and we're able to use a small needle, much like acupuncture, to find the correct location around their tailbone. And through it, we can thread a tiny little temporary wire about the size of a hair. And what we'll do is then we'll connect it to a small battery about the size of a toonie on a belt externally, and we'll tape it down to their back, and they're able to go home for 3 to 7 days. And it's acting like the pacemaker, but it's an external temporary one. And it essentially gives people a test drive. It allows us to see whether they're going to respond to therapy, by how much. And based upon this trial, both the patient and us as the physicians can make the decision as to whether they would like to go ahead with the implantation or not. And so once they pass this trial, what we're really looking for is at least a 50% improvement in their symptoms, and we could then move them forward to the actual implant. If, for example, the trial doesn't yield the results that we like, we can actually do what's called a staged implant, where we can go to the operating room with the patient asleep. We can put the lead in using an X-ray for guidance, and then we'll still do that external trial with the external battery for 2 weeks. But then if they do pass, they'll come back 2 weeks later and have the battery implanted. So there's essentially 2 different ways for us to test, but we always like to test just to ensure that patients are going to respond. How well does sacral neuromodulation work? It works actually really well. We can see here clinical success rates between 65 to 80%, which is great. And in fact, about half of those patients will become completely dry. So you can see with the urgency incontinence, about 80% of patients will be improved. And about half of those patients, 45%, will actually be cured completely dry, with the remaining being more than 50% improved. Same with urgency frequency, and same with urinary retention. There can be adverse events, of course. Patients can experience some pain or discomfort at the implant site. They can develop new pain. There's something also called lead migration. If they were to move in a certain way, that small little wire can move. Infections are possible, certainly rare. you can have some changes in bladder and bowel function as well as undesirable stimulation. Of course, all of these can be fixed with some additional surgery to move things around. So essentially, this is the algorithm for patients coming in. This applies to both fecal incontinence as well as overactive bladder. They're going to come in. We're going to try conservative measures. We're going to try behavioral modification. We're going to try oral medications. If that doesn't yield the results we're looking for, and they choose to do neuromodulation, they'll come in for the test evaluation, and then based upon that, they can have the implant. These are just the sizes of the implants relative to each other. You can see the 5-year non-rechargeable battery is maybe twice the size of 2 quarters, so maybe like a toonie. And this rechargeable system is also really quite small and thin, and like a small memory stick. This is just an example of what we're doing. So we're trying to target a nerve that is at the sacrum or the tailbone, and a specific one. It's the S3 nerve root, so we have to be really quite precise. It's a very safe procedure. There's really not harm or damage. We're not actually anywhere close to the spinal cord. We're well below where the spinal cord ends, but we're really trying to get that small lead or wire very close to the particular nerve, the S3, that goes down to the bladder and the bowel. This is an example of some x-rays from my operating room where we just show the placement of the lead. And you can see here there's these 4 dots that allows us, these are like a battery, pluses and minuses, and we can change where the stimulation is occurring on the lead, so we can get closer or further away to the nerve. And then the battery is implanted under the skin. So everything's under the skin. There's no external parts. People can go swimming. They can do day-to-day activities with nothing on their bodies. And of course, it is covered by OHIP. As I mentioned, there's 2 different systems available, and patients have the choice. I would say the vast majority, 90%, select the InterStim 2 system, which is the non-rechargeable. It's really simple. You put it in and you can forget that it's even there. So with that, that was the first of the refractory 3rd-line options, so sacral neuromodulation. I will make a note that there is another type of neuromodulation called tibial nerve stimulation, so something that stimulates the ankle. It's not available in Canada anymore. Hopefully in the next year or 2, we'll have some new devices coming onto the market, which are small implants that place down around the ankle. Why the ankle? Where actually the nerve that goes to the bladder ultimately splits off, and part of it will travel down the leg. And so we're actually able to stimulate a specific nerve in the ankle, which will send a message backwards up to the bladder. So if anyone has read about percutaneous tibial nerve stimulation, or PTNS, that's what it refers to. Moving on to Botox, or OnabotulinumtoxinA. This is a very effective therapy, which has been in Canada for many years, at least going on 15 plus years. It is proved, of course, around the world, that it's certainly not experimental. It's very much has a great amount of evidence that I will tell you about. Many of the early studies were actually performed in Toronto. And of course, it is covered by OHIP for people over the age of 65 and most insurance. So I always think about Botox as a middle ground strategy because it's not surgical, but it's certainly more effective and a bit more invasive than the medications. Botox is indicated for the treatment of overactive bladder symptoms of urgency, incontinence, urgency and frequency in adults who have inadequate response or intolerant to medications. And so, again, we really want to be stepwise in our approach. We want patients to try the conservative things, try the medications, but of course, if medications don't work or they're getting side effects from the medications, Botox is a really great option. And the other thing, of course, is that Botox is really much more widely available. Sacral neuromodulation is only available in Ontario at my hospital, the Toronto Western Hospital, and it's actually not even available in every province in the country, whereas Botox has a much greater footprint across our healthcare system. It's been adopted much more easily, and so there are many hospitals with many urologists across Ontario and Canada who are able to offer Botox locally. So what does Botox actually do? It does 3 things to the bladder. It increases the bladder capacity, meaning the size. It increases the volume of the first detrusor contraction. In other words, remember when we said the bladder was squeezing at inopportune times? Well, here we're going to relax the bladder so that it really doesn't squeeze until the bladder is much fuller. And then last is compliance, which is really the stretchiness of the bladder. And it increases the stretchiness, which is a good thing. The other really important thing is that Botox decreases the pressure inside the bladder. And that can be really important for a number of patients, including those who have neurological conditions like spinal cord conditions or spinal cord injuries, because they can essentially have very high pressure with a non-stretchy bladder, and that can cause damage to their kidneys because the pressure builds up. And so Botox is really important to be able to relax bladders and decrease the pressure. It has been shown to also improve urgency, much like the neuromodulation. It decreases that sudden sense of having to rush to the bathroom. And in fact, it may have some effect on those afferent nerves. So not only is it working on the muscle, but it's actually working on the nerve right in the bladder to prevent some of those sensory messages from traveling up to the brain. So how do we do Botox? Well, the way that I explain it to patients is that it's a liquid medication, and we're able to directly place it into the bladder. So you don't have to take a pill. You don't have to drink anything. There's no systemic side effects. So unlike pills where you're going to get dry mouth and constipation and dry eyes, the medicine doesn't pass through your digestion. It goes right into the target, right into the bladder. Different hospitals will have different routines as to how they give the Botox. At some hospitals like mine, we do it under local anesthesia. So we can put some numbing solution like lidocaine through a catheter into the bladder. We let it sit there for about 20 to 30 minutes, and then we perform a standard cystoscopy, which is a camera into the bladder. And with a tiny long needle, we can actually inject the medication. Some places do it under intravenous sedation or general anesthetic, and other places, in fact, don't use any freezing. They've moved to just using a newer type of needle that's really easy to tolerate and really sharp, and they can do it, in fact, with minimal to no anesthetic. So the whole procedure only takes a few minutes. Taking apart the bladder freezing part, from the time we put in the scope to the time we've injected the Botox, it's really only a few minutes. And when it's done, patients can actually get up and walk out, and depending on the type of anesthesia, they can drive themselves home and go to work or whatever they like. The Botox can be administered through both a rigid scope or a flexible scope. So there's a lot of options there in terms of what urologists may have. Typically, we've done around 20 small injections spread out across the bladder. Some urologists are moving to do fewer injections, which is great. And it's, again, very well tolerated. In terms of side effects, the vast majority of patients are going to have no side effects whatsoever. 94% of patients will have no issues with being able to empty their bladder. There's a very small sliver of patients, around 6%, who at the very beginning after receiving the Botox, after a week to 2 weeks, will have a harder time peeing, because what the Botox is doing is it's relaxing the bladder muscle. And for some reason, and we don't really know why, the bladder muscle can become too relaxed. And if the muscle's too relaxed, then it actually doesn't have enough power or force to get the urine out. So this is a temporary thing before that week or two where the retention is occurring. Remember, in only 6% of patients, they may have to use a catheter. Botox typically lasts on average around 6 months. For some people, it's a little bit shorter. For some people, it can be a little bit longer. I have people typically coming every 6 months, so it's about twice per year. It's like going to the bladder dentist. But of course, for some people who have a very significant amount of overactivity, it may wear off quicker, and they have to come every 3 or 4 months. And I have people where the Botox lasts 12 months, and they only come in annually for their injection. So as I mentioned, there are very few cases of needing a catheter. And of course, the nice part is that it's always temporary. It will never be a permanent side effect of the Botox injection. The Botox will ultimately wear off, and you'll be able to urinate once again. So how do I explain Botox to patients? I think I explained it a little bit, but this is really important because I think there's a lot of mystery around all of these third-line therapies for refractory overactive bladder, because they're just not commonly offered and commonly discussed in the office. So Botox is simply a liquid medication. We put it directly into the bladder. We're going to freeze your bladder. It's going to take just a few minutes. As I said, I really want to focus on the non-retention rate. We give everybody a dose of antibiotics beforehand to prevent urinary tract infection. A few practices teach patients how to catheterize beforehand. I don't. The reason is because, again, 94% of patients will never need to catheterize. So I would really rather teach those people who need to catheterize if it comes to pass. And as I said, the efficacy is around 6 months. So how well does Botox work? Well, it's really good at significantly reducing daily episodes of incontinence. In this research study, it was 3 times better at reducing leaks compared to placebo in this research study. And we also see that when you ask patients on this treatment benefit scale how well they did 2 weeks, 6 weeks, and 12 weeks after the Botox, the vast majority of patients will state that they greatly improved or improved with the Botox. And so that is a really important statistic in terms of the success rates, and not too dissimilar from the neuromodulation statistics. Remember, those were around 68 to 80%. What about reductions in urgent urinary incontinence at 12 weeks? Again, we see patients doing really well. About 60% of them are having a 50% reduction. Just under 50% are having a 75% reduction, and just over 25%, a quarter of patients were entirely cured or dry of their leakage. So all of those, I think, are really encouraging. We also see a significant decrease in nocturia. Many of these patients will be up at night repeatedly, having to go to the bathroom. It may be from urgency incontinence. And so the Botox was twice as good compared to placebo at reducing nighttime urinary episodes. A big component, we talked about this at the beginning, is quality of life. Overactive bladder and incontinence significantly negatively impair quality of life. We're able to assess quality of life on these measures, and we can see here that Botox significantly improved quality of life in these metrics compared to those who received placebo. And so it's not only working on the bladder, but patients are feeling the improvement. And the same, of course, is true for the neuromodulation. There's been studies looking at when patients wanted to come back for retreatment. With the placebo, of course, after 12 weeks, almost everybody is going to ask for retreatment because this was the earliest that they could ask for. But of course, those who receive Botox, it goes all the way out to 6 months. And that's really where we get the 6 months from, is that it's the median time to request for Botox retreatment. There's really good safety data for Botox. Aside from the retention, urinary tract infections can occur. They're around anywhere from 10 to 25%, depending on the study that you look at. And again, we really like to give everybody a dose of antibiotics beforehand. Of course, if they're on a blood thinner, we also want to hold that ahead of time. What about giving Botox over and over? You could imagine that unlike neuromodulation, we give it one time, patients are coming in for 1, 3, 6, 10, 20 Botoxes over the years. And so this study here essentially showed that Botox remains very effective even after the 3rd, the 4th, the 5th dose. And so people do not appear to habituate or get used to the Botox. It certainly can be a long-term treatment for them. So I'm going to summarize, and we've talked for about half an hour, leaving a bit of time for some questions and answers. So in summary, OAB and urgency incontinence, they're really prevalent conditions. It affects about 15% of the population have an overactive bladder. And of course, over the age of 65, it's about 1 in 3 adults. Remember, we want to have a stepwise approach to the treatment of urgency incontinence and overactive bladder. First-line therapies are the cornerstone. We want to avoid extra fluids. We want to avoid caffeine and alcohol and spicy foods, things which can trigger or worsen bladder dysfunction. The second-line therapies, which are the medications, are really good. Remember, there are 2 classes of drugs: the anticholinergic drugs, or antimuscarinics, and the beta-3 agonist. These medications can be used by themselves. They can have the dose increased, and then of course they can be used in combination. And sometimes it just takes the combination to get the right amount of control of the bladder. Now, of course, in a subset of patients, they won't respond to these first or second line treatments. These would be considered refractory. We would typically try maybe 1 or 2 medications from the one class and then the beta 3. So you're really looking at 2 to 3 medications total. You don't go through 8 treatments. If you do make it to be a refractory case, you'll be referred to a center that offers either Botox or neuromodulation. And I've been able to show you Botox and neuromodulation have been approved. They've been around for decades. They're safe, they're very effective, and they're covered, of course, in our public healthcare system here in Canada. So I think the most important thing is just getting the word out. Patients need to get the referral to a center that offers it. They need to ask their physicians if they're not being offered so that they can find the treatment that best suits them. So with that, I purposely tried to leave us time so we could ask questions. I'd like to thank the Canadian Continence Foundation once again for the opportunity to speak to you all tonight, as well as our sponsors for tonight's program, both AbbVie and Medtronic, who have helped bring this all together. And with that, I'm going to stop sharing my slides. If you want to just take your microphone, I don't know if you can speak and unmute, or you can put some questions into the Q&A. So thanks very much. I'm going to take a quick look at the Q&A. What are causes of urge incontinence other than childbirth and menopause? If some are experiencing since childhood urgency incontinence, what could be the cause? So that's a great question. So there's 2 different things. Overactive bladder becomes more common as we get older. So people in their 60s, 70s, 80s, it's about 30% plus. There are a subset of even young people, and it's probably around 4 to 6%, who could actually have overactive bladder. So it's certainly possible, like at the Sick Kids Hospital, to have children who develop overactive bladder. The most common cause of urgency incontinence in children will be some sort of abnormality. So they're born with a spinal cord abnormality. They could have spina bifida or a neurological condition. The vast majority of people of all ages will not have an underlying cause. So we call it idiopathic overactive bladder, which means idiopathic means there's no cause. And so we don't have a good explanation as to why people develop overactive bladder in life. When patients ask me, I sort of make the parallel analogy to vision. So for some reason, we all have good eyesight, but many young kids you'll see are starting to wear glasses. And as the population gets older, increasingly more people's eyes will start to fail. They'll get blurry vision, and they'll have to start wearing either reading glasses or glasses all the time. And nobody knows exactly why. Some people's optic nerve changes, etc. So it's the same type of thing. It's just a neurological change. There is a question around contraindications to neuromodulation, spinal stenosis, morbid obesity. That is true. So not necessarily spinal stenosis, but abnormalities in the spinal cord. So if someone has spina bifida or sacral agenesis, or a tethered spinal cord, or other sort of spinal cord abnormality, then we probably would not do neuromodulation, because we really need the nerves to be in the correct anatomic orientation for us to be able to place our lead. Morbid obesity, it has to be really quite morbid, but we do have extra long leads that we can try and do into people who are bigger. But of course, there is an upper limit to everything. There's a question around Parkinson's disease and the cause of incontinence. So the answer is actually yes. So Parkinson's disease is a neurological condition. And one of the manifestations of Parkinson's can be changes in bladder and bowel function. And one of those changes can actually be the development of an overactive bladder. So we have many patients with Parkinson's disease, multiple sclerosis, multisystem atrophy, and other neurodegenerative disorders who do develop overactive bladder. The good news is that most of them will respond to medications. And if they don't, we often offer them treatments like Botox into the bladder. I think that you can raise your hand if you want, or just unmute your mic. You can be anonymous, and you can also ask a question if you wish. Otherwise, you can continue to ask questions in the Q&A. You can just give me a topic and I'm happy to discuss. So I'll tell you that one of the reasons that, so neuromodulation is quite an expensive program, and that's why the government, at least in Ontario, has sort of designated one center to be the place. There's a few centers in Quebec. They do a small volume. There's another pretty big center in Halifax at Dalhousie. And then there's nothing across the country till you get to Edmonton, and then nothing in the West. So neuromodulation is, again, a really great option, but not widely available, whereas Botox is performed a little bit more, much more widely by a variety of urologists and some urogynecologists as well. There's a question around anxiety playing a role in OAB. So it's a great question. There is a phenomenon for sure where stress, emotional stress, anxiety can exacerbate urinary symptoms. It's not necessarily that it's making the OAB worse, but there are other causes. So people, when they're stressed, they drink more, they drink coffee, they're drinking water. We have a lot of university students who present to us through the health clinic around exam time. And the other, one of the main causes of urinary frequency and bladder problems is something called pelvic floor dysfunction. So pelvic floor dysfunction is essentially a tightness of the pelvic floor. So there's muscles that essentially sit, and your bladder sits inside. And if those muscles become very tight and tense, they can cause urinary symptoms. And so some people clench their jaw, some people shrug their shoulders, some people get migraine or tension headaches when they're stressed, and some people get a tighter pelvic floor. And so anxiety and emotional stress can actually tighten the pelvic floor and make some urinary symptoms worse. And so in that case, the actual treatment is pelvic floor physiotherapy. You need to go to a pelvic floor physiotherapist, a specialist of physiotherapy, who can do the proper exercises to relax, first of all, diagnose that you have a tight pelvic floor, and also relax the pelvic floor through exercises. There's a question around how much does the implant cost for out-of-province patients. So as long as you're Canadian, there'll be no cost to you. The way it works for out-of-province people is that you get your home province to approve you to come to Ontario or one of the other provinces that provide it. You got a letter essentially stating that you've been approved by the government of British Columbia or Saskatchewan. And then when you have that letter in hand, your specialist can refer you to our center, and you can get the neuromodulation done. There is a question from Ursula, if you would like to ask your question.
Hi, can you hear me?
Yes, go ahead.
Yes, I had Botox treatment done about 2 years ago. I found it was extremely painful. I don't think I had much any what you call lidocaine, is it, or anything inserted beforehand, but I may have had some. But I did finish the treatment, but just barely. And then I had about 4 urine infections in the next year and a half. So I certainly wasn't given any antibiotic or anything like that. So I had said no to having it having it again. But maybe if I did have it again, I should ask for all those extra treatments.
Yeah, I think that, it even happens in my practice where sometimes people come in and say, that was a great injection. And then the second time they'll say, that was a great injection. And the third time they'll come in and say, oh, that one really hurt this time. And, I do the same technique every time, and we've done, hundreds and hundreds, thousands of these. So, there could be a variety of reasons why the lidocaine didn't work. It wasn't in for the right amount of time, or it typically is. But remember, the bladder has all of these folds when it's collapsed and has a little bit of fluid in there, and you may not be getting the lidocaine into all the little parts. So we try our best, but of course, we can't always guarantee it to be a perfectly, painless procedure. But the good news is that it's really short. It's really only a few minutes. But I can assure you that every practitioner performing Botox and neuromodulation does their best to make it, as comfortable as possible for patients. There was a question around whether my GP can refer, or does it need to be a urologist? Any physician can refer. Most overactive bladder is treated in the primary care setting. Remember that urgency, frequency, nocturia, the storage symptoms of overactive bladder is a clinical diagnosis. It doesn't require any specialized treatment. It doesn't require any fancy testing done by urologists like urodynamics. And so most family doctors will start making recommendations for conservative treatment. They will give the anticholinergic and beta-3 agonist medications. And hopefully, if those medications aren't working, they'll know to send to a urologist. But you can be sent directly from your family doctor. There's a question around people with spinal cord injury, if they can use neuromodulation. So this is an interesting question, because historically, up until about 6 months ago, sacral neuromodulation was not MRI compatible. In other words, the lead and the battery we had could not go into an MRI below the shoulders. And so most people who have spinal cord injury, Parkinson's, multiple sclerosis, other spinal cord injuries have routine MRIs. And so we couldn't give them neuromodulation. So in fact, there really isn't much experience or research looking at spinal cord injury and neuromodulation. The problem with spinal cord injuries is that you have a disruption in the messages being sent up and down the spinal cord. And so the neuromodulation may actually not work, because as we talked about, those afferent and efferent signals. So the vast majority, the cornerstone of management in the spinal cord injured patient would be Botox. And Botox has actually been an amazing advancement in the management of what we call neurogenic overactive bladder, or neurogenic diffuse overactivity. And so most people with spinal cord injuries are getting Botox, and it works really well for them. There's a question around choosing between Botox and neuromodulation. This is tricky. Of course, it depends where you live. You may ultimately just be referred to somewhere that has Botox, as it's more widely available. I think it's an individual question. Do you want something that's a surgery with an implant, or do you want to come in for those repeated cystoscopies with the injection? For some people, they think surgery is very invasive. For other people, they perceive repeated cystoscopies with injections are very invasive. So it's a bit of a subjective personal view. The literature, the research would show that they're actually equally effective. So there's not one that is better than another. Botox and neuromodulation are considered equivalent treatments. They're on par with each other. So I'm not here to say one is better than the other, because they're not. There's a question around whether there's a treatment for someone with severe cognitive impairment or aphasia. So typically, Botox is where we would tend to go, as opposed to neuromodulation. Neuromodulation requires some part of cognitive involvement. You need to understand the remote control and the programmer, etc. And so it'd be a relative contraindication. So for people with major cognitive issues, impairment, we'd like to give them the Botox. There's a hand up from Sumi Shaley, if you'd like to ask your question.
It's just thank you for presenting this webinar. And I'm also I have these issues of incontinence. So I just have one. I'm curious about the causes. I was told that mainly it happens in old age women and because of childbirth or menopause, but I have been experiencing since my I think my childhood, the urge incontinence and stress incontinence started happening after, I think after the childbirth recently. So what are the causes? Like it can happen to anyone?
It can, yeah. So the vast majority of people who have overactive bladder don't have an identifiable cause. We call it idiopathic overactive bladder, and it can happen any time in your life. It could happen when you're in your 20s and 30s, and we don't necessarily have a reason. If you have no neurological conditions, some people have things that weren't diagnosed. So, we have people who come in their 50s and they've had problems since their teens, and we'll do an MRI of their spine and they had an undiagnosed spine condition. So we do get surprised from time to time that there is a cause, but the vast majority of time we do not identify something. There's a question around how long is a reasonable time frame to allow medications like anticholinergics to work. That's a great question. So the guidelines and my recommendation to assess medical therapy is 3 months. So a 12-week trial of any of the medications taken every single day consistently is what is required to see whether these medications work. Some people experience side effects like dry mouth or constipation earlier before they actually start to see improvements from the medication. And that's a problem because a lot of people will stop the medication at the first sign of a side effect, and they don't give the medication enough time to work. Additionally, a lot of the side effects tend to get, they go away or they get weaker over time. And so it's really important if you're going to be trying one of these medications to give it a really good try for 12 weeks or 3 months. Every single day, even if you're having side effects, I would say just try it for that full period of time before you decide, because your doctor is going to want to know if it was an adequate trial or not. There's a question from Catherine around whether urodynamic studies should be done before Botox or neuromodulation. So the answer is they do not have to be done. There are many centers who offer third-line therapies who do not have urodynamics available. Urodynamics is a special type of testing of the bladder to see what's the function. Of course, if there's a clinical question, if something is not clear, if the physician wants to confirm the diagnosis, then of course urodynamics can be performed, but I don't think it is a must. If it is done and it confirms the diagnosis, it makes proceeding with the treatment a lot easier. There's a question around concern using medications that may contribute to dementia. I think this is a really important point with the anticholinergic or antimuscarinic drugs. So there's that main class of medications for the bladder, and they have been linked to the onset of dementia later in life. There've been a number of studies looking at thousands of people who took overactive bladder medication in their 50s, and then in their 70s and 80s, they developed dementia. And there's a slightly increased risk of that happening. And so people are being a bit more cautious, or certainly more aware of the prescription of this particular group of medications. It's something definitely to be aware of. There's a question around the cost of Botox for under the age of 65. It's a good question. So certainly in Ontario, most provinces over the age of 65, it's covered. There's a limited use code. People do not pay. Of course, if you're on ODSP or some other form of insurance, there's no charge. Most private insurance plans, so if you have insurance through your work, do have Botox covered. And then of course, if you really pay out of pocket for Botox, the prices range, but it's going to be probably around $400, give or take, for an injection, if the last time I checked. There's a question on where will this be recorded? I hope so. That's up to we'll ask our tech people in Canadian Continence Foundation. So we have 5 minutes left in this 1 hour presentation. I want to thank again everybody for taking the time this evening for joining, and I really appreciate the Q&A because it keeps the conversation going. There's a question around OAB resulting from radiation. Yes, so radiation to the pelvis can result in changes to the lining of the bladder, and you can develop overactive bladder. And we would approach it the same way. So we would approach it through conservative measure, medications, And you could, in theory, try both Botox or neuromodulation. I don't think that there may be other things happening with radiation, so it can be complicated, but certainly all of the things we've discussed tonight could potentially be options for someone who's had radiation-induced problems. There's a question about how many injections do you need to take for OAB? So the number of injections isn't the main deciding point, it's the dose. So for people who have the run-of-the-mill, what we call the idiopathic overactive bladder, the dose is usually 100 units. And for those people who have neurological conditions, spinal cord injury, multiple sclerosis, Parkinson's, it's 200 units. We usually do anywhere from 10 to 20 injections. It really just depends on how much medication and the physician's preference. There's one more question from Sumi, if you'd like to ask your question. If anybody else has one last question,
sorry, Doctor,
otherwise
just
we'll.
one question. If you could just one more minute, I would take. So I have heard about like they just make you sit on a machine and then they'll make you do like 10,000 Kegels. So how is that effective? Like, does it help? It's like they have machines and they do that.
Yeah. So there's some special machines that make the pelvic floor contract. This would be for stress incontinence, so coughing, laughing, sneezing, leakage. It would not be for overactive bladder or urgency incontinence. And I will tell you that the evidence for it is very limited and very weak, and therefore it is not something that I would recommend to my patients. So it's not recommended by any guidelines. It's not recommended by the Urology Society or any other organized medical group. So I would not recommend the chairs. So with that, we're about 2 minutes shy of 9 o'clock. So we'll start to wrap it up. Again, I want to thank all of you for taking the time this evening for joining us. The Canadian Continence Foundation is a fantastic organization, which is really the voice for Canadians who suffer from all forms of incontinence. They're there to provide support. They're there to provide information and education. They're there to bring together medical professionals, allied healthcare professionals. Remember, we need occupational therapists, physiotherapists, psychologists, social workers, all working with the urologists, gynecologists, because it takes many different forms of treatment. So with that, I'd like to thank Jackie Cahill from the Canadian Continence Foundation, and I wish you all a very pleasant evening. And thank you once again to everyone and our sponsors for joining. Thank you.